Welcome, viewers and listeners, to the Health Revolution, the program that shows you how to have a life of vibrant well-being. In a world full of noisy health trends, we bring you clarity. In a sea of fads, we reveal the science-backed strategies that truly work. We explore physical strength, emotional resilience, and mental mastery. These are the keys to an enriched life. Join us for inspiring interviews with champions who conquered life's health challenges, fueling your journey. Are you ready to unlock your potential? To live with vitality and purpose? Then join the Health Revolution. I'm your host, Adriana Morrison, health and fitness expert, speaker, and a mom who understands. Let's embark on this transformative quest. Together, we're about to change the game, starting now.
The information provided in this show is intended for educational and entertainment purposes only. Viewers should use their own discretion and consult with a healthcare professional for personalized guidance and recommendations. Welcome, everyone, to the Health Revolution. We're excited that you are joining us today. I'm your host, Adriana Morrison, and no matter which way you are tuning into us, please do not forget to hit the subscribe button because we want to stay connected to you. Also, in your show notes at the bottom of this screen, you will find some important information pertaining to today's episode. And I'm excited and eager to dive in. We are talking about breast cancer and in terms of the research, awareness, and advancements that are out there. Of course, we do know that here in the United States, 1 in 8 women are diagnosed with breast cancer. Globally, the numbers are just about the same. And today we are continuing this global conversation of how we are moving the needle forward in terms of advancements. My guest today is someone who we definitely want to be speaking to. First, have a look at this.
Meet Dr. Sanjay Warrier, a preeminent breast cancer surgeon based in Sydney, Australia. As the immediate past president of Breast Surgeons of Australia and New Zealand and a visiting medical officer at BreastScreen New South Wales, Dr. Sanjay is deeply involved in the front lines of breast cancer treatment. He leads 3 clinics dedicated to combating this pervasive disease, employing a mix of advanced surgical techniques and compassionate patient care. Dr. Sanjay's typical day revolves around managing his surgical practices and overseeing the treatment protocols from diagnosis through the various stages of breast cancer. His commitment to the field extends into his significant role in clinical research, where he is actively involved in developing new treatments and advancing medical knowledge. Renowned for his contributions to numerous peer-reviewed medical research papers, Dr. Sanjay is a frequent presenter at international medical conferences. These platforms allow him to share his innovative approaches and discuss global advancements in breast cancer treatment with fellow experts. Dr. Sanjay's professional life is a testament to his dedication to eradicating breast cancer and improving patient outcomes through surgical excellence and groundbreaking research. Today, we get to dive into all of this. Dr. Sanjay Warrior, welcome to the show. How are you?
Hi, thanks for having us on the show. Yeah, really good. It's early in the morning here. And yeah, it's nice to be able to, touch base and, with people from around the world.
I'm always eager to have these global conversations. I know you're in Australia, and the 18-hour difference is something I'm still trying to get used to. What led you? Let's dive in. What led you into breast cancer research, the surgery, and the advancements in technology to help combat this disease?
Yeah, I think starting with why breast cancer. I think when I was training, I really liked anatomy if I go back. And then as I did surgical specialties, I just found personally it very rewarding to be dealing with female patients predominantly, who were very grateful. I was getting, I just found it very rewarding. Generally, our outcomes are quite good, which so it's a very satisfying specialty. And then on the back of that, it was then looking at ways to train, and we worked out in Australia and the UK, when we do breast cancer work, we generally will do quite interesting work where there is a focus on aesthetics and form, and that was very interesting from a training perspective. But then the research bit comes in, I think, outside of doing a lot during my fellowships. I think it was just driven by the idea of putting the patient in the middle and looking what's the current best care and what are the potential improvements that we could make to those cares so that we're not stagnant and moving forward with better treatments.
So here in the United States, 1 in 8 women are diagnosed with breast cancer. I'm curious, what are the stats for Australia and the UK, and then globally? What are some trends that you're noticing that just transcend, doesn't matter where we are on the planet?
Yeah, that's a good question. I think, like you mentioned, Adriana, before, that in America it's 1 in 8 females. I know with our stats in Australia, we're at 1 in 7 females, which trying to put that into perspective, if we have 6 of our friends in the room, one of us during their lifetime potentially will get breast cancer. So it's incredibly common cancer to get with time. And when we look at when we look at basically across the world, it's pretty similar. There'll be 1 in 8 or 1 in 7 in terms of stats.
And so with the research that's out there, what are you noticing is the areas that we need to dive into? Is it that at times that we're not diagnosing, or that breast cancer is not being diagnosed at an earlier time? I'm curious about the obstacles that the research continues to address, and that it's just more of a story developing situation.
Yeah, I think if we just look at anything with time, generally the way that we view things at this point in time may be very different to how we look at it in 5 to 10 years. And we've learnt that through time, like the way we looked at it in the 1980s in terms of breast cancer compared to now is very different. If we go back, and there are multiple aspects to this, but if we go back far enough, we initially, and this is historically, thought that breast cancer management was a systemic disease, but that we didn't really have treatments for it. And then it sort of migrated to the concept of that the bigger the operation, the better in terms of treatment, including taking skin and taking muscle, and we call that a Holstedian mastectomy. It was an old school mastectomy, but it led to incredible deformity for patients. And then we moved to an era now where it is multidisciplinary. It involves not sitting in a silo, but working in an ecosystem of care. And there's been an improvement and in overall understanding of all our treatments. And but as a breast surgeon and being on the coalface of management, you've got to be able to understand what both me and my colleagues are doing so that you can work and advocate for the patients and give them the information to be able to go through potential improvements versus quality of life measures with time through treatments. So when
go ahead, I'm sorry.
No, yeah, you go. Like basically with regards to when we talk about our improvements with time, we basically are talking about, we've got these great new ways and paradigms of treating patients, but even despite all that and improvements in outcomes, still the most important thing is being able to pick the cancer up early. So from sitting on the front line, if I see a patient that presents with a breast cancer, like it makes me sort of relax if it's an early cancer compared to someone who's diagnosed later. So despite our improvements in our outcomes, if I can find a cancer that's earlier, we know that patient, potentially their journey will be less and the likelihood of recurrence down the track will be less.
Take me through the different stages of breast cancer. And very many of us are familiar with, the earlier the stage, the better. But can you break it down in sizable terms of
Yeah,
what is an indicator of stage 1 and 2 and beyond?
yeah, look, I think really I don't use it so much like the stage, but like basically in my head, I think an early cancer is generally, if it's less than 2 centimeters and not in the lymph node, is generally a good, like what I call early breast cancer. And then once it gets beyond that 2 centimeter mark, it's starting to become moderate. Once it hits 5 centimeters, which is a sizable size, that is a larger tumor. And we call stage 3 is when the lymph nodes are involved. And stage 4 is when there's disease outside the lymph nodes. So what we know with breast cancer is that there were varying theories about how breast cells move. And the first theory, Holstedian theory, was that it actually moved via lymphatics. We understand that there's both that and the Fisherian theory, which is it also moves via blood vessels. So there's probably a mixture of both in terms of how breast cancers can move. So what the staging is telling us is when a patient is diagnosed with breast cancer, this is painting a picture of what our starting point is. It doesn't mean necessarily in 2024 that their quality of life and our ability to treat is not there, but the reality is the earlier the better. But we are seeing a lot of patients with stage 3 now where we're able to treat it really well, and they're not coming back with recurrences.
Are there certain characteristics you're seeing that are presenting in 2024 that are more of a trend that were not present in prior years? Are there maybe unique trends in symptoms, in how a patient presents? Is there anything that strikes you of what trends that you're noticing today?
I think that the thing that is quite striking, which it's always been there, I think there's always been a group of patients that potentially were younger that were diagnosed with breast cancer, but we are seeing a lot. And it's just this whole concept that breast cancer happens just between 50 and 74. I think that's probably a cost benefit. Why that's a general screening recommendations. But when you talk about, are you at risk of breast cancer below those ages, definitely between 40 and 50, that there is the option of screening here in Australia during that period. But we are seeing a reasonable amount of cancers. And even if we look at the data in Australia, there has been a subtle increase in cancers below 40. So with that, and that's even if you take into account what you'd expect, basic variations, it's still more than that. So what are the factors that are playing into that is it's probably multifactorial, but it's just understanding that below 40, we really shouldn't be sitting on symptoms. We should be having an idea and being proactive about what our breasts feel like, and where everybody, it's not easy to have an idea, but it's nice to at least have a plan in place, understand what your family history is, helps, I think, and then having an idea generally about, what do I do if I have a symptom is important as well.
So a lot of the research that's out there, obviously research will be ever evolving. What are some things that you're noticing or what you're excited about for what's to come to treat breast cancer patients? And then of course, it's important to point out that it's not just women who get breast cancer, but men
definitely.
have been diagnosed with, are diagnosed with that as well. What are some unique facets of the treatment and technology that you're starting to see that maybe the rest of us don't know?
Yeah, I mean, just based on the audience, I think it's nice to just understand that when we talk about management of breast cancer, it is part of our goal is to actually get the right, it's a nuanced management, but it is important to understand that with packaged care, which involves multiple streams, that for any individual patient, understanding what the goal of those treatments are and what's going to give them a better survival outcome is important. So we have seen we have seen over a period of time a significant improvement in the ability to give medications in varying forms to improve the outcomes for patients, and understanding when we potentially will give that prior to surgery is an important factor. And why that is, is because if we can actually assess response for some of these cancers and work out how those treatments are working, we can then work out and discriminate between those that are responding really well and those that aren't responding well. And those that aren't responding well are the ones that really need those second line therapies. So what I like to do is when I see a patient, I say, look, we need to do two things. And it's a very anxiety provoking time, but we need to do two things. I need to know what it is. So, and we break the cancers up into three types generally, which are ones that don't have receptors on them, that we call triple negative tumors. There's a second type that has a particular tumor within the nucleus of the cancer that we call HER2. And the third one is estrogen receptor or hormone producing cancer. So I like to break, which is the commonest type. So they're the three basic types of cancers. And so for the triple negative and the HER2 positive, we have a number of agents that work that really shrink them down. And by the time we're operating now, particularly if I look at the triple negative using immunotherapy now, we're looking at response rates close to 50%, and which is great, which means when we take it out, half of the time, the tumor's not present at the operation. And within the HER2 positive group, with dual agent therapies, we're looking at around 70% to 80%. And that means that 20% of the time there might be residual disease, but often it's smaller in the amount. So we can really use these therapies. To improve the way that we direct management, but also assess response to treatments. Within the hormone group, I think it's a different interplay, because within that group, some of our discussions are, can we actually block hormones, and do we need chemotherapy for this group? So there is a group that potentially, and this is a big group of patients, that may actually benefit without chemotherapy. And so it is about finding that balance, how much benefit, how responsive it is to those systemic harder core treatments compared to how important is it to block estrogen for that particular cancer. And these are, so that's what it is. And then the second part of the question is, where is it? So the second part of the question is, where is it? And with that, that's basically making sure we don't rush in, we do appropriate imaging, and with the cancer diagnosis, that may include an MRI on top of a mammogram and ultrasound. And then also for those that we think is more advanced, we generally would do a PET CT, which is a glucose avid CT scan. So
this is incredible. We're going to take a break. We will be right back. Don't go anywhere. Don't go anywhere. We will be right back after this. Hello, Wellness Warriors. Welcome back to Fit Bites with Adriana. Today, let's shine a light on a crucial aspect of mental health, and that is the power of rest. Now, rest is not just about getting enough sleep. It's about giving our minds a break from the constant hustle. Now, in our fast-paced world, we often forget that rest is a form of self-care that's essential for our mental well-being. Now, one way to incorporate rest into your life is through the practice of mindfulness. And taking just a few minutes each day to sit quietly and focus on your breath can help clear your mind and reduce stress. Another tip is to create a restful environment at home. Declutter your space, add some soothing elements like plants or soft lighting, and create a cozy corner for relaxation. Now, don't forget to set boundaries around work and technology. Designate times when you can disconnect from emails and social media to give your mind a break from digital stimulation. And remember, rest is not laziness. It's a vital part of maintaining a healthy mind. By embracing rest, we can improve our mental clarity, creativity, and overall mood. So let's commit to making rest a priority in our lives. Stay tuned for more Fit Bites, and here's to a more rested and resilient you. Welcome back to the Health Revolution. Welcome back, everybody. My guest today, Dr. Sanjay Warrier. He is a consultant breast surgeon who is on the cutting edge of breast cancer awareness, the research, and he is internationally sought out for medical conferences. And Dr. Sanjay, before the break, you were diving into the different components of the different characteristics of breast cancer. And I was fascinated with what you were saying. The one question I do have in mind is to ask you is, if someone has a history of other cancers, if a man or woman, but say in particular a woman who has a history of previous cancers, what are the chances that if she is diagnosed with breast cancer, that it is more of an aggressive, or maybe that time is of the essence to address it as quickly as possible?
Yeah, that's a great question. I think with regards to that, it's a very it depends on. We generally don't see the other cancer as necessarily impacting the management of this particular cancer. There are exceptions to that. I think I had a patient that was having actually a concurrent treatment for a particular colorectal cancer, and then came via BreastScreen and was diagnosed with a breast cancer. So that became interesting because we had to manage two cancers at the same time. But if it's a historical cancer that they've had, I think it doesn't necessarily impact the management for that cancer. Where it does make a difference potentially is if the types of treatments they've previously had. So if they've had a type of chemotherapy for the other cancer, it may impact the way that our oncology colleagues may think about the chemotherapy component. And but using an example of if it was like a skin cancer and then you're presenting with a breast cancer, often they're unrelated common cancers. However, saying that, like, there are associations between other cancers and breast cancer. We know that. And a common female type of cancer that's associated with breast cancer is ovarian cancer. So ovarian cancer and breast cancer together, there is a group of patients that have a particular gene that we call BRCA or BRCA, and there are two types of that, and they are generally at a higher risk of breast cancer. Not always, but commonly they have a family history, and there are groups that are at higher risk of that.
And it's fascinating because I've always wondered if the characteristics of a previous cancer, and obviously they're all independent of one another, if it just somehow influences the nature by which breast cancer would evolve in if it influences the spread or the staging and how things are evolving in her or his body. So and what you're saying is that obviously you're taking that into consideration, but it's not the biggest plot twist out there, or
Yeah, it generally doesn't tend to be, which is good. Like I think, from a positive perspective, it is easier to just have that ability to segment our therapies, and ultimately it makes it less complex for the patient. It is obviously tough as a patient to go through multiple cancers through your lifetime, but it does happen, and not uncommonly, and particularly with a number of cancers being quite common, like colorectal, for instance. It's common across male and female in our Anglo-Saxon population, at least here in Australia. We've got some great sun, we've got some great beaches, but there is a high rate of melanoma, and so there's a lot of awareness around skin checks, general awareness about doing your cervical screens. At 50 here, we do fecal occult blood tests, but we also, there is a move to doing earlier colonoscopies. Even there are people who really feel that we should be from 40 considering checking the colon. And then breast, we have our program running optional from 40, but running from 50 to 74.
You bring that up, and now I'm curious, where would you like to see screening begin? And where could there be greater preventative measures that could be implemented with this?
Yeah, it's interesting. I think the first thing is understanding and appreciating that there is a problem. Like, I think if you don't appreciate there's a problem, then there's no solution. And then when you talk about screening programs, it's about the economics of it, unfortunately, as well. So like when government agencies look at, okay, how am I going to run a program? They think about cost effectiveness across the entire population. But then so then it becomes nuanced, I think. But there is no doubt there for a less than 40-year-old female, there isn't an umbrella net that's capturing that group. And then there will be those proponents who feel that, are we over treating certain people and putting them through anxiety and all the rest of it? But generally, if you ask the person on the street what they'd prefer, I think they'd prefer to not go through treatments or be picked up earlier. So that really is a high-level discussion with government about how to best manage this potentially lower risk group, but still at-risk group. And then I think understanding factors that are at play within those population, and then being able to give a simple message is important as well. So when we talk about factors, I think we're talking about that we know that having a family history makes a difference in terms of that lower than 40. We know that having a gene mutation makes a difference, and there are a number of genes outside of BRCA. And we know that a non-independent breast factor that increases your risk is having denser breasts, which is not how they feel, it's how they actually look on a mammogram. And so I think there needs to be tailoring of the screening for that younger group, and definitely more information in a packaged way is important so that they're aware of their risks. And that's why when we were talking about earlier, that the way we approach it now and the way we approach it in 10 years may be very different, essentially. But definitely at the minimum at the moment, I think patients should be able, or females should be able to have an idea of how to examine their breasts and have an idea of the density of their breasts, have an idea of their family history. They're the three things that are probably, I think, a minimum. And then basically looking for changes and not just assuming that the changes are just going to come and go, essentially.
And if I may add, I want to pull up a slide that we have, and it's a concept that you shared with me prior to today, and I'd like to share it with the audience, with the viewers. Can you talk a little bit about this concept of look, lift, and feel, and where and what it represents, and the details, and how does one approach this concept?
Yeah, I think like the drive for it was, and I've been a consultant for 10 years. So I started as a consultant surgeon in 2014. So the drive for it was just seeing over again and again patients coming in where their partner may have noticed a lump and that they've potentially not noticed the lump. And so it became clear that understanding and being able to examine breasts or being aware of it, of their breasts, was not as common as we would like. And this is in a group that potentially don't have a screening program. So they don't have any way of actually reacting. They don't have any information really. They don't have any systematic information, at least, to the population at a population level outside of advocacy groups that are often working within the groups that have already got breast cancer. So I think that was the thinking behind it. And so when we're talking about this group, I would like to say that as a proviso that that this is also a group that potentially their health is important, but they're often at a busy time in their lives. They might have 2 kids or 3 kids, or having to juggle work, having to juggle finances, having to juggle the family, their mother. So they're with regards to finding time for themselves can't always be easy. It might be down on the priority list, and trying to have that time for yourself at that time is important, because without looking after yourself, you can't look after others, essentially. And how do you get that message out there before we get to the look, lift, feel?
So the one thing that I find that seems to be helpful is I'm looking at the look, lift, and feel, and the concept is self-examination. Yes?
Yeah, definitely. So like we've spoken about the fact that these are people that potentially are busy in their lives. So having something that's catchy to be able to remember and think, okay, how can I be systematic about it? But try and find a way to just have an idea of what my body feels like is the concept behind it. And we've got 3 components to it. It's look. So we learn early that before diving in like a camel with their head into the sand, I think the first thing is to step back and look at the breasts, and basically we'd recommend just looking, and then from there, the lift component is, so what you're looking for firstly is you're looking for, are there any changes on one side versus the other? Are they similar? Is there any skin changes? Is there any changes associated with the nipple? And also then there are basic things you can do. If you push your hands against your chest wall and flex you can also see whether or not there's any retraction on the skin sometimes. So there are dynamic movements you can do on the look just to see. but at the minimum, it's checking all the skin. And then with the lift, it's basically lifting one hand up. So lifting one hand up. And then the feel is just feeling with the other hand, essentially. Now, there are multiple ways to feel. When we talk about feeling, we talk about there are ways to do it, concentric circles. There are radial spoke techniques, which are basically working in and out. And the key component to it, to be honest, just cover the entire, be systematic and cover everything. So if you're working through, just make sure there are no areas that are missed. And that includes the nipple areola. And it also includes under the arm. There's an area here of breast tissue, which is we call the axillary tail, that needs to be felt as well. And then right under the arm are the armpit lymph nodes, or axilla. So that's important as well. And sometimes that's easy to do in the shower, I think, potentially as a way of doing it, just so you're, but having an idea of what your normal is important to be able to understand when something comes that isn't normal, essentially.
Now, obviously, for a woman who's had any type of augmentation, if she's had any type of, so that's something that's a little bit, that could present differently. Would you say that maybe her limitations could be where, like, say, where the implant, if she's had implants, where the implant is laying inside the breast wall, the breast tissue?
Yeah, the important thing to understand is with the augmentation surgery, there are two to three places they could be sitting. It could be sitting completely under the muscle. It could be sitting partially under the muscle, or it could be sitting completely over the muscle. But whichever way it's sitting, it should still be sitting below the breast tissue. So it allows still an examination of the breast tissue, essentially.
Okay.
But
because that's something that's not talked about, but there is that population of women who have had augmentation, who have had implants. And so then the misconception could be, well, I don't know how to do that, or maybe that doesn't apply to me, but you're clear on that can still, she could still.
Yeah, definitely. Below that age, I think at the minimum, I would do that. I think it's a great topic to sort of move into, is the augmentation space, because we've definitely seen an increase in that space. And I think it's important that large group of people have the ability to understand that there are risks associated with their breasts, the same as everybody else. And that I think there are a couple of misconceptions associated with implants. I think the first one is that you can't do a mammogram with an implant. And we do have views that we can do to lift the breast tissue away from the implant and still get great views on the implant. But our starting point would be an ultrasound. But in the group that are above 40, I think you can still do mammograms on them. And then we also have other techniques for assessing implants, and the escalation technique outside of an ultrasound would be MRI as well. So there is radiology there if there are symptoms that can assist with assessment. And it's important with an implant to remember there are two risks. One is the breast risk, which still sits at 1 in 7, but there's also a risk of that implant with time. So when somebody has an implant, at that particular point in time, like a new computer, they will not be concerned at that time that what will happen with time. But then when you have your computer and you've had it for a period of time, then it starts playing up. And that's what happens. There, obviously, computers are probably subtly built to, they have a lifespan, and the implants are built to try and last as long as possible. But the reality is, with time, if you've got a 10-year-old device compared to a new device, they will be different. And I think it is important to separate out the breast implant health from the breast health and understand that both are important. And there are things that happen with implants, and that includes our body responds to them over a period of time that we call capsular contracture. Sorry, Adriana.
No, I was going to say, we're going to take a quick break and we're going to continue this conversation. Don't go anywhere. Don't go anywhere. We will be right back after this. Thank you so much for watching The Health Revolution. Our show is growing, and it's all thanks to viewers like you. No matter how you found us, please hit the subscribe button so we can stay connected and continue to deliver amazing content to you. And now we want to give special thanks to Biomed Mobile IV for sponsoring The Health Revolution. Biomed Mobile IV is Colorado's top mobile IV therapy service, servicing throughout the state of Colorado. They offer an array of vitamins and above and beyond safety preparation. Biomed Mobile IV, your dedication to health and wellness is exactly what our show is all about. And we thank you for your support. Welcome back to The Health Revolution. My guest today, Dr. Sanjay Warrior, he's a consultant breast surgeon, and we are talking about the innovative ways to address and approach breast cancer awareness and the research and technologies that are surrounding the ever-evolving space. And Dr. Sanjay, before the break, we were talking about the newer space of those with women with breast implants and how some of the concerns and the different situations that you've seen in addressing breast cancer and perhaps some of the connections between women who have implants and then breast cancer, just the different trends and the rates. And what are you noticing that are there some characteristics that women need to be more aware of if they happen to have implants? The lifespan of wearing implants, is there a direction in the conversation that she needs to go with her doctors?
I think, I think, and when at any time in your life, there is the option of having implants, and that I think that once that's good, but like the reality is when you have the discussions often with the surgeon for the insertion of the implant, at that point, the focus is on basically getting you to have the implant. And like, obviously you want to research and do that at the appropriate time, but then the important thing after that is like often the follow-up drops and the models aren't built to really follow up. And for understandable reasons as well from patients, they don't want to be going and coming all the time generally after they have implants, particularly if they're younger when they're doing it. So I think it is important to understand that implants have a profile of risks that happen with time. And that includes with time, what happens is the body responds to the implant and creates a capsule, which can vary in terms of how it feels. That we call that capsular contracture, and it's something that there are operative and non-operative managements for it. But it's just being aware that if you're starting to notice differences with the implant, it is worth making sure that you get that checked by a health professional who has a practice that deals with implant-related complications. And the other thing is with implants is if you go in with an intention with the implants, I think it is important to be happy with the device, like the way it's done. So if you're not happy with the result, get another opinion. I think ideally you get it from the same person to start because you're keeping that connection. It's always difficult when someone else comes in. They'll always generally there will be a bias, surgical bias there, I think. But if you're actually, hang on, this is not what I think, then at that point it's good to get opinions from trusted people, particularly if it's not met what you wanted. And so in terms of the other things that can happen with time, the implants sitting a certain way, they can rotate, they can migrate laterally, and depending on the type of implant, what the other thing, depending on where the implant is put and depending on weight loss and other things, what we can see is rippling of the implant, which is where it's almost like when you see a basketball, and when a basketball loses some of its air, you start to see those ridges, and that can happen in the top part of the implant. Thankfully, yeah, go for it. Sorry, Adriana.
No, you're good. You're good. And this is, what I find intriguing is that, because there's a greater emphasis in making sure that younger and younger women are aware of just the self breast exam, the screening that doesn't hurt to get as you're younger. I can only imagine the types of conversations or the types of scenarios that are coming up that younger women or newer generations are just presenting with different situations with breast health, implants or not.
Yeah.
So.
Yeah, definitely. And I think it is important, just understanding those things. And the other couple of things just to mention, there is a rare association with a type of lymphoma with implants. Not common. I'm not aware of any cases with smooth implants, but and when we talk about smooth versus textured, the texture is the actual capsule of the implant, but a micro-textured device is still used in Australia, and there is a rate currently of about 1 in 20,000 is the current figures for that rare implant-related cancer. It's not common, but some of the types of implants that had higher rates, up to 1 in 2,000 with one particular group, have been removed from the market. So that we do have, at least in Australia, we have smooth and micro-textured or type 1 and type 2 devices, and both are relatively safe, but it is important for patients to be aware. But importantly, the thing is, you have your implant, these are the things that can happen. If you notice any change, swelling on that device, or any change at all, I think it's important to get a check. And even if you don't have a change, I think it's important to be checked and to check yourself for breast. And then outside of that, if you're noticing differences, to see someone who is able to assess appropriately rather than dismissively, to make sure you're covering what's happening with your device.
Yes, we're going to take a quick break. We'll be right back. Don't go anywhere. We will be right back after this.
Hi, this is Clara Capano, your host for Women Winning Their Way, where we talk about how you can create success all on your terms. Join us Thursdays at 8 p.m. Eastern Standard Time on the Limelight Network here on E360 TV.
Welcome back to the Health Revolution. Welcome back, everybody. We've been spending some quality time with Dr. Sanjay Warrior. He's a consultant breast surgeon and based out of Australia. And Dr. Sanjay, where can viewers find you?
Yeah, so probably the best place, if you want information, will be through my website. I think my staff are very open. We do Zooms as well. Like if there are questions and but we are pretty responsive, I believe, to questions as well. So if there's any questions at all, confidentially or other, like if you want information, we're happy to help. I think one of the feedback to me from patients has been that we are patient-centered. We spend time with people. We try and work out basically what is the best treatments for them, depending on what it is. And yeah, like we understand the interplay of factors, having been a consultant for a long time, that are at play. And there are multiple driving factors when we talk about treatments. And that includes the ability to understand with a diagnosis, patients are actually going through stages potentially of grief. So being able to work through options so that without confusing them is a skill, rather than just say, because you have a particular ability to do something, using it on everybody. So there is a lot of non-technical aspects that are important in treatment, particularly breast cancer.
And for 2024, I know that you've spoken and you continue to speak at medical conferences and just different groups in this space. Anything coming up for 2024?
There's so much exciting stuff, and we've definitely, I think a really interesting area just to be aware of, and is the whole concept of reducing treatments. I think that is because we get our standard of therapies, and then trying to actually reduce them is a difficult concept to do, and it needs trials to do it. But we now have a number of trials running that have demonstrated potential. We might be able to, for those early breast cancers, which we were calling less than 2 centimeters, there may be a role for potentially not having radiotherapy at the time of the surgery. I mean, after surgery. So, which is our standard of care at the moment. So, and the other bit is with those that have lymph nodes involved, the concept of actually not taking all the lymph nodes out, but taking out just a number of nodes post systemic therapies and leaving the rest of the nodes so you don't have swelling in the arm. So we are balancing how good our treatments are versus the complications of our treatments, and in a trial-based way are getting better and better data that there are improvements in terms of quality of life. Our goal is ultimately that for the patient that's diagnosed with breast cancer, ideally at 5 years, they're moving on. That's the ideal. Obviously, you know, they're getting through an episode in their life, and they're ultimately moving on. And so for us to be able to do that, we have to make sure that our treatments aren't over-treating them, so that they're not living with the ongoing consequences of their treatments with time.
And this is hopeful and optimistic because of the, you know, of where this is going. And I wish we had more time, and clearly we are out of time. But Dr. Sanjay Warrier, thank you so much for your time, your energy, your input, and the fact that you're able to share how this presents and how optimistic this looks. Thank you for your time.
Thanks, Adriana. Thanks. A shout out to you yourself. I was looking, there's a lot of awesome stuff you're doing. So keep it up. Wish you the best.
Thank you. And for all our viewers, of course, you can find our website on the internet, thehealthrevolutiontv.com. You can always subscribe to our newsletter. You can also email us for any show ideas you'd love for us to cover, because we over deliver. And then upper left-hand corner, you'll find the QR code if you want to quickly catch that instead. And then, of course, you can always find us on the Achieve TV channel on E360 TV every Tuesday and Thursday. That's 10 a.m. Pacific, 1 p.m. Eastern Standard Time. That is all the time that we have. Thank you so much for joining us. Until next time, take care of yourselves. We'll see you soon.